Consortium. We will start with taking the official roll call. So Nagla, if you would take roll call, we'll go ahead and get started.
Okay. First, Dr. Alcides Amador.
Here.
Dr. Taiwo Babato.
Here.
Dr. Diane Chapa. Dr. Melissa D. Phillips. Dr. David Farmer.
Present.
Dr. Wayne Goodman.
Present.
Dr. Hisham Ibrahim. Trina Ida. Lee Johnson.
Here.
Dr. Andy Keller.
Good morning. This is Shannon Gangerty. I'm on for Andy today.
Thank you. Dr. David Lakey.
I am here.
Dr. Sarah Martin.
Here.
Dr. Octavio Martinez.
Here.
Dr. Nathan Maxwell.
Here.
Elizabeth Mayer.
Present.
Dr. Cheryl McCollum-Smith.
Covering clinical service today. I'm not sure if she will be able to join or when she may be able to join. We're down a faculty member.
Okay, thank you. Dr. Tara Mitchell.
Here.
Dr. Charles Nemiroff.
Here.
Dr. Jeffrey Newport. Brittany Nichols.
Here.
Dr. Nikisha Oliphant.
Here.
Dr. Renee Olvera.
Here.
Dr. Stephen Pliska.
Steve is out of town today.
Okay, thank you. Dr. Tariq Raji.
I'm here.
Olga Rodriguez.
Here.
Scott Schlaflin. Sue Shell. John Scott.
Here.
Thank you.
Sorry,
Dr.
Sue Shell is here.
It was Sue Shell. Sue Shell, okay. Sorry. Thank you.
Thanks.
Dr. Suarez.
Yeah.
Luann Southern. Dr. Peter Thompson.
Here.
Dr. Karen Wagner.
Here.
Dr. Sarah Wakefield.
Here.
Dr. Patricia Watson.
Here.
Dr. Laurel Williams.
Hello.
Hello. We have 25.
We have 25 individuals, so we're at quorum. We can go ahead and officially start. As we start, want to welcome our new member to the executive committee of the Texas Child Mental Health Consortium. And as I do that, Dr. Raji, also want to thank Dr. Carol Tominga. I think I saw her here on part of the virtual team. And she's been part of our team from the very beginning, before we were the Texas Child Mental Health Care Consortium. When we were just the meeting of the chairs of psychiatry, she was instrumental in providing her support and getting us going. And as everyone knows, she has decided to retire, and we are again in debt to all the work that she's done, but also very excited, Dr. Raji, that you are here. Maybe why don't you introduce yourself a little bit? You and I had a little bit of time to talk in a meeting not too long ago to orient you to the work, but I want to make sure all your colleagues across the state know that you're here and have a chance to meet you.
For sure. Thank you. I'm Tariq Raji. It's really an honor to be part of this table and be part of this group. I'm no stranger to Dallas, Texas. Actually, I trained at Southwestern in the department that I'm rejoining, back in 2005. And I did the fellowship then moved to Pittsburgh, did the fellowship in geriatric psychiatry. Pittsburgh was not cold enough for me. I stayed there for the last 18 years. I decided to come back to that. So the department is an amazing department. Being in Texas is a wonderful place to be back. Looking forward to supporting this consortium. So thank you, everyone.
Good, welcome. It's great to have you here. With that, I think that's the only new member that we need to introduce today. Is that right?
Yes.
Okay. Let us go to the minutes from the September 16th meeting. Everyone should have had that. If you could take a quick look, and then I need an official motion to approve it to the second.
So moved.
Very good. Dr. Nemiroff, do I have a second?
Second.
Second by Dr. Suarez. Any further conversation? Hearing none, all in favor of approving the minutes from last meeting, signify by saying aye.
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 Opposed, nay. Anyone abstain? Hearing none, let the record show that they were unanimously approved. Let's move forward then to Molly. I saw you there a little bit ago, Dr. Molly Lopez. We'll give an update from internal evaluation on CPW and our CAP fellowship.
Awesome, wonderful. Thank you. All right, thanks. So we're going to talk a little bit today about workforce initiatives and share some data with you all. You can go to the next one. Going to start off with really sharing about CPW resident rotation experience, and then we'll wrap it up with some experience, some data about our CAP fellows and CPW placements. Go ahead. All right, so just a quick reminder about some of the goals of our CPW evaluation. So some of the goals of CPW are to really expand the availability of mental health resources by developing those training opportunities for residents and then supervising them at LMHAs and other community health providers. So both providing a great training experience, but also expanding access to mental health resources within our community. And then also to increase the number of Texas-trained psychiatry residents who go on to work, hopefully in the public mental health system upon completion of their residencies, and hopefully also stay in Texas. So next slide. So we instituted in December of 2022 a survey of CPW residents. The way that it works is as they end their rotation at a particular training experience, they receive a survey. To date, we have 116 surveys that cover that time from December 2022 to October 2024. So I'm going to share some data from those surveys. On your left, you've got a graph just kind of sharing the different years that those trainees are. We have the most trainees representing years 4 and 5 in the surveys, and then also their identified gender as well. Go ahead to the next slide. Here is the race and ethnicity reports from those survey respondents. And just a reminder, because people do more than one rotation, they will show up in the surveys multiple times as well. So, all right, next slide. So some of those findings, we asked respondents to share how satisfied they are with the number of individuals that they were able to see as a part of their training experience. So you'll see across the first 3 boxes there, high levels of satisfaction with both the children, the adolescents, as well as the adults who are seen within those different training experiences. We also ask about whether or not the training experience was more difficult to navigate within that system than other rotations. And about 39% said that it was a little bit more challenging to navigate within that particular training experience. Okay, next. We also ask a number of questions that get to kind of resident satisfaction with the experience. I'm going to share them broken down by one of the characteristics of the training that we asked. We asked about how many hours they were spending in that rotation. And so I'm going to share the next few questions kind of broken down in that way. So this question was, I would recommend this rotation to other residents. So kind of a general satisfaction question. And you'll see there that we do see some differences based on the number of hours, and those who are spending most of their time, at least 9 to 40 hours in that residency experience, have higher levels of satisfaction overall. Okay, the next slide. Similar, this is a question about this rotation provided me with an excellent educational opportunity. Again, high scores in general, higher for those who are spending more time in the experience per week. And the next question, this one is about the rotation really increased my understanding of community psychiatry. Again, we've got great results from that. Folks are rating that highly, particularly if they are in those rotation experiences for a significant number of hours. We did break some of this data down by some other categories as well and did not see differences. So for example, we looked at the number of other trainees who were in that same rotation with them, kind of as an idea of wondering if you have multiple trainees kind of working together in that learning experience, are you more satisfied with the experience? And we did not see differences in that way. And we also looked at the length of the training experience. For example, if you are rotating for a month versus for 6 months, is there a difference in satisfaction? And we did not see that either, at least at this point. We also asked a number of qualitative questions for folks, and so I'm going to share some of those pretty quickly, but you do have them. For the most part, we asked folks if they're willing for us to share their response as a quote, and if they said yes, you may see some of these as direct quotes, and then others are identified more across multiple folks. And so if it says in the narrative that it's a theme, that means a number of people shared that exact same, or not exact same, but that general response as well. So first we're going to start off with questions about experiences where the trainee said that they were either more or less interested in community psychiatry because of these experiences. To start off are kind of the folks who are like, maybe this didn't help them become more interested in community psychiatry. And some of the reasons that they provided were feeling like the residents being supervised, not by a community psychiatrist, didn't give them the level of experience with community psychiatry that they wanted. Folks also talked about not feeling fully integrated into the system itself, not fully understanding how to help patients navigate through different assistance programs, to make referrals within the system, or to understand some of the different services that might be available that they might want to collaborate with. There were also folks that talked about having not enough access to non-medication supports, such as nutrition programs, et cetera, and worried that kind of that limited level of supports and services might keep the outcomes from being where they wanted them to be. They also talked about just some of the challenges of navigating the systems. We sort of saw that in one of the earlier responses. And the primary things folks talked about were difficulties with the EMR, not having enough time for appointments, or having a lack of assistance from clinical staff that may help with taking vital signs, things like that. And then also we had some who disliked that telehealth experience that was a part of their rotation, or the primary purpose of their rotation. But we also had folks who talked about how experiences increase their interest in community psychiatry. So if you'll go to the next one. Folks talked about being able to really work with a wide array of different settings in which to see individuals and how they really liked that variety that community psychiatry has for the different settings. Folks felt, or one individual felt like it was really helpful to be able to focus in on primary care with patients with mental health conditions within kind of an integrated primary care and psychiatric system. Folks talked about the diversity and complexity of the individuals they were able to see, and that I would say is probably the widest shared response of why folks felt like the experience really helped them develop an interest in community psychiatry. And folks also talked about the opportunity to work with people in multiple disciplines within team-based structures and really appreciating that opportunity to be able to engage with folks from different backgrounds. And folks also had the experience of really seeing the need for child and adolescent psychiatry in the public system and really felt like they understood the impact that they could have within that system. And lastly, folks shared about the valuable one-to-one experience they had, being able to match with an academic teacher in that one-to-one basis and really improve their skills. All right, on our next slide, we asked them about some of the key lessons that they learned on the rotation. So I'm going to share a few of those. Folks talked about being able to see somebody for the first time engaging with psychiatry, and that was really powerful, as well as an opportunity to spend more time with individuals and really get to know their stories. Somebody talked about the excitement about being able to see the wealth of integrated care that happened for patients, whether that's counseling, case management, substance use, all being integrated into one system, and that they hadn't had that experience working in private clinics. Similarly, talking about kind of the ability to see individuals really improve when they did receive that multifaceted, multidisciplinary care, and also being able to see the impact for individuals who were not hit by the really significant burden that, the cost of treating serious emotional disturbance and serious mental illness can lead to. And we also had somebody who shared that while they initially didn't like telehealth experiences too much, this rotation gave them the opportunity to really see the value of telehealth, especially for folks who are in rural and remote areas and how important that can be. All right, next slide. We also asked for what ideas they might have for improvements to the rotation experience. We had folks share that they wanted more time in the rotation, as well as more time to see individual patients. They also talked about having increased educational opportunities on dual diagnosis with IDD and mental health concerns. And then folks also talked about wanting to have some initial training at the beginning to just set the groundwork for common child psychiatry disorders and treatment approaches. Additionally, some folks really wanted to have more opportunities for in-person treatment rather than telehealth, and felt like they shared both that they felt it would have been a better training experience, but also a better experience for the individuals in care. Folks talked about they wanted more opportunities to work with that diverse multidisciplinary workforce. They wanted time to work with peer specialists, with therapists, with case managers to really see those different roles. And then also folks wanted some opportunity for training as they got to the agency about how that agency functions, how to make referrals, how to navigate the system, what specialty programs might be available. They wanted to kind of be more fully embedded into that system. There was a number of comments. It was pretty common for folks to say that they wanted an improved EMR. Not sure we can impact that one, but I wanted to share it. And then also some consistency in terms of who's providing the supervision and wanting that to be a little bit more standard across the training experience. All right, and I thought I'd just share this quote because I thought it kind of encapsulated a number of different things from one individual who really shared that they were able to connect a transition age youth patient, so a youth and young adult with both counseling and employment assistance, and then watch them over the next year achieve recovery status and remain employed in counseling. And I just thought that nicely encapsulated the value that folks expressed around both that opportunity for that multidisciplinary treatment approach, but also the having some time to really watch the outcomes of young people play out. All right, I'm going to shift a little. I'm trying to go quickly because I know we don't have a lot of time. I'm going to talk a little bit about our next stage, which is the CAP Fellowship outcomes. So again, as a quick kind of level setting, the Child and Adolescent Psychiatry Fellowship is a 2-year specialized training in child and adolescent psychiatry. And some of the short-term goals of the fellowship are to increase the number of medical professionals who are in Texas, specializing in child and adolescent psychiatry. And then long-term goals to increase the number of child and adolescent psychiatry to the child population, increase the ratio within the state, as well as to reduce the number of medical and mental health professional shortage areas, and to reduce those wait times that we know are common to see child and adolescent psychiatrists. So a little bit about some of the outcomes. You all have probably seen this before. This is just kind of level setting to see the growth in the number of positions filled over the years. So you can see prior to initiation of the Texas Child Mental Health Care Consortium, we had 27 child and adolescent psychiatry positions filled. And then over the years, those have grown with those in red representing those funded.
So we have no concerns about any cognitive decline.
Dr. McCollum Smith, we can hear you. So if you could please mute yourself, that'd be great.
And that he.
Okay.
All right, next slide.
Okay.
So let's share a little bit about what we know about the outcomes, the longer term outcomes. So this is going to cover information from academic years 2023 and 2024. And that's the point at which we started gathering information about placements for those individuals who are graduating out of those programs. And so we have data on 85 CAP fellows and 77 CPW residents as a part of this. And probably one of the, the things that we have been most interested in is whether or not those trainees stay in Texas. So you will see here, over half, so 63.3% of the CPW residents stayed in Texas, and almost 80% of our CAP fellows stayed in Texas as their next placement. So pretty exciting. Some other elements of outcomes. Where did they go? So you'll see here the types of organizations that individuals ended up in. Again, the highest number here is our public systems, so our hospitals and LMHAs and FQHCs as well. So that's pretty exciting. And we also have the majority of individuals in placements that serve children and adolescents. And if you're curious about those who leave outside of Texas, here's a map of that. Not really any pattern. It's not like we've got the majority going to one state or the other, really going across the country as well. And then the type of placements that individuals are in, 54% outpatient, 21% inpatient, and a variety of others, which include continuing on to perhaps fellowship, additional fellowships, and other training experiences as well. All right. I think that is it. If anybody has any questions, I'm happy to do my best to answer them.
Very good. Thank you, Dr. Lopez. Why don't we, again, just open it up for any questions or any comments from the group?
Yeah, Dr. Lakey, if I could
Yes,
real
Lee.
quick. This is Lee Johnson. I'm sorry, I'm calling in from another meeting I'm at. But the presentation was fantastic, Molly. Thank you. I would love to visit with you offline about the possibility of bringing that presentation to the full executive directors consortium for our system, I think there could be a lot of interest in the data. And I just, I mean, I haven't been in these conversations for as long as some of the others here have, but I mean, the goal here was to, create a pathway into, FQHCs and local mental health authorities. And I just love that the data is actually showing that that's happening. So I know our folks would be very interested in hearing this presentation. So I'd love to work with you or whoever is the most appropriate person offline to get that set on our next agenda as well.
I think that's great, Lee. Again, thank you for being here. And as we noted from the beginning, the goal is to build our workforce, and as part of that, have people that will work in the local mental health authorities. And the data that we built it on actually came from UT Southwestern. That when they did this and had the ability to have residents work in the local mental health authority, they saw the opportunities to work in the local public health authority as part of their career in the future. And so it's nice to see that that looks like to me like it's occurring, and it looks like they're staying here in the state of Texas. 80% of the CAP fellows staying in the state of Texas. I think that's a good story. It doesn't surprise me that it's higher for the CAP fellows than for the residents, because the residents may go on for some different additional training somewhere else in the state. We'll have to see in the future whether they come back, but having 80% of the CAP fellows funded by the legislature staying in Texas, I think is a good story. And so thanks. Then we go to Octavio and then to Karen.
Yeah, thank you, David. Molly, great presentation. Just a quick question on demographic variables. Was there any question in reference to the language or multiple language capability of the residents? I mean, just given our demographics in Texas, it'd be nice to know how many can actually or feel comfortable saying, doing clinical work in Spanish versus other languages, depending, like in Houston, where, there are other languages that could be beneficial. But just wondering, because I didn't see that.
Mm-hmm. There was not, but I think that's a great suggestion to add. I will say there was a qualitative comment that reflected on really enjoying and appreciating being able to provide services in Spanish. So qualitatively, absolutely. But I think
Thanks,
that's a
Molly.
great suggestion to add.
All right.
Dr. Wagner?
Molly, do you know how many of the CAP fellows went on to academic institutions? I'm asking that because we need more people to be able to train these fellows.
I can probably get that to you.
Thanks.
Mm-hmm.
Very good. Dr. Amador?
The consortium funded CAP fellow positions. Do we know if any of those were with the combined general psychiatry and child psychiatry, or do we just mean separate, that these were, traditional fellows in the sense that they did, 1 and 2 years, not kind of like a combined type of track?
Molly, could you hear that?
I did. I'm not sure if it might be that training directors can speak to that better than I can.
I think these fellows are the traditional fellowship after residency and not the combined. And so this was expansion. We'll hear later today some work that's occurring at UT Southwestern on triple board. But the programs that we were able to invest in at the beginning were the traditional fellowships and expanding of those. And so we were able to expand traditional fellowships at 3 new institutions and then expand the number of fellows trained. Olga?
Hello, I just had a quick question about the telehealth experience. So at the first part of the presentation, I just want to make sure I understood that. So they did or did not like telehealth?
That is a good question.
Okay.
I think it was mixed. There were definitely some folks that said they would prefer to have in-person experiences, but there were also folks who said that the experience let them kind of realize the importance of telehealth in their work to get to more remote areas. So I think it was a bit mixed.
Okay, thank you.
Dr. Wakefield?
Yes, hi. I was just going to say that There were, I mean, not in a triple board program, but we were able to do a creative kind of child track as was recommended by ADPER to increase people going in and interest of child and adolescent psychiatry. The funding only paid for the child fellowship years of that track, but we were able to do that and it's been very successful.
And Sarah, correct me if I'm wrong, but I think yours is one of the programs that was able to stand up with these funds. You and UNT and
We were.
And was it Tyler? Okay, yeah, very good.
Yep. So we have fellowship positions that we did not have a fellowship at all prior to these funds, and so we now have our 4th year of child fellows, which we're really excited.
Yeah. Yeah. And Dr. Sarah Martin, I see you there, and the reason I want to call you out is because I stole a quote from you to put in our report to the legislature related to the impact that this rotation had on influencing the career choices of your residents. And I guess I'd like the rest of the group to kind of hear that story. And Lee Johnson, I think this is, again, kind of a story that you should hear related to kind of how this is impacting career choices.
Okay, yes. So before we started all these community child psychiatry rotations, as well as we have our residents rotating on CPAN and TCHAT, every year we were just really anxious about, are we going to get enough fellows? And so one of my fears when we expanded the fellowship, as did everyone else in Texas, and there's all these new fellowships in Texas, I thought, oh my gosh, now we're really not going to fill. And you know what? It has not been the case. We have been filling. We've been having lots of, last year we had 5 out of 8 residents going to child psychiatry. One of them went to a different institution, but then 2 of them maybe, I don't know. Anyway, but we have been filling and so it's been really great to see. And it's just something that it was kind of the opposite of what I was expecting. And when I talked to them about it, they like the rotations. They're really enjoying them.
Yeah. And Sarah, correct me if I'm wrong, but prior to these rotations, you had 0 of your 8 going into child and adolescent psychiatry, and now you have 5 of the 8 going in. Is that correct?
Well, some years, yeah. We always had 1 or 2. So
okay.
But we never consistently were full. We always had open slots in child psychiatry until this happened. So.
Any other questions? Seeing none, again, thank you, Molly, for the great work that you guys are doing. I really appreciate the analysis and the surveys, and there's a lot of work that goes behind getting these numbers, and again, really appreciate the work that your team's doing. So let's now transition to our external evaluation. Dr. Savas and Peskin, I think I saw both of you here just a little bit ago. I don't know which one of you will take the lead.
I'm here, Melissa. Good to see everybody today. So we're going to switch gears a little bit and talk about our survey findings from the providers and TCHAT survey that we did during fiscal year 2023. So next slide. So we surveyed enrolled providers who used CPAN in the past 12 months, and we surveyed them between August and September of 2023. And our goal was really to identify a diverse sample of providers across the HRIs and based on social vulnerability, so economic disadvantage, and also population density, so rural, urban charter classification, and then also district size. So we sent the survey to 428 providers, and we received responses from 124 providers. Overall, providers reported very favorable perceptions of CPAN, and when we asked them about their recommendations and future use, almost all of them, so 98%, indicated that they would continue to use CPAN in the next month. That was 96%. 98% indicated they would recommend CPAN to other providers. And then we also asked about their perceptions of any trainings that they had received. And when we asked about trainings, the majority of providers reported that either they or other clinic staff did not attend any trainings, or that they didn't know if they attended a CPAN training. But of those who did attend a training, overwhelmingly, they found it to be very or extremely helpful, and no providers reported that the training was not at all helpful. So next slide. Overall, more than 70% of providers reported that their knowledge, skills, and competence to provide mental health care increased moderately or very much due to CPAN. And then regular CPAN callers were more likely to report these outcomes compared to occasional callers. And again, this was in the last 12 months. So all really good benefits to CPAN users. We also asked some open-ended questions. So we wanted to get at their perceived benefits of the CPAN program and also areas of improvement. Similar to last year, an important benefit-related theme that emerged was accessibility of the CPAN program. And respondents specified that the accessibility of the consultation services, information, and resources provided by the CPAN program really helped them better to address pediatric mental health needs of their patients. They also noted the lists of community resources that were tailored by patient zip code, and they found those to be very helpful as well and reduced a burden on physicians. Similar to what we found in the quantitative data, we found providers reported that CPAN increased their confidence in treating patients with mental health needs. And really, they mentioned that the program allowed physicians to care for patients without the need for a referral, or to bridge their care until they could see a specialist. Another theme that emerged was the perception that the education and training provided by CPAN was beneficial. And several participants mentioned that the opportunity to earn CME credits through CPAN's presentations and training opportunities was valuable. And just noted here a quote from a pediatrician: "It is an amazing resource. It is very beneficial to run cases by a psychiatrist. The referrals are great because they take patient insurance and location into consideration." We also asked about key barriers and recommendations for improvement. The first barrier were, the time constraints in busy clinic schedules. They often noted that making calls to CPAN could disrupt workflow despite the program's benefits. Respondents also noted the limited referral options for uninsured patients. They did note that some referral lists don't always accommodate uninsured patients or underinsured patients, and some clinics have long wait times. And so the recommendation here was to have improved community resource connections, so specifically to update referral lists to offer more affordable and viable resources for uninsured and underinsured patients, and also to ensure that community resources are accessible. So to offer telehealth options for underserved patients who could not travel during work hours. And finally, respondents also indicated a lack of awareness among colleagues that may be limiting the program effectiveness, and the recommendation here was to increase outreach and awareness through expanded community engagement. And one physician assistant noted, a lot of community providers do not know about CPAN. Greater community outreach to pediatrician offices in the community would ensure more people know about this program. Next slide. We also wanted to quickly give you a summary of the findings from our TChat school staff survey. So we also surveyed TChat program implementers, one program implementer per campus. And similar to what we did with CPAN providers, we also identified a diverse sample of enrolled campuses across the HRIs based on rural-urban charter classification, economic disadvantage, and district size. So we sent the survey out to implementers at 483 campuses, and we received responses back from 226 school staff. We found that the The implementers who responded to the survey reported very high satisfaction with the TCHAT program. 89% indicated that they would recommend TCHAT to other schools, and 93% intended on continuing to use TCHAT in the next 6 months. Respondents also reported very favorable perceptions of TCHAT effects on student outcomes and staff capacity. So between 44% and 63% of respondents indicated that because of TCHAT, staff perceived students to have decreased behavioral incidents, better attendance and grades at school, and school involvement. And over 90% reported that TCHAT increased school staff capacity to meet students' non-educational needs. And this is an increase in percent agreement compared to last year. Last year it was 79%, and this year it was 91%. So that was nice to see. And then also we have some qualitative data. So they also noted some key benefits and some key barriers and recommendations. One key benefit was the free, accessible mental health care for underserved students. In particular, they noted that TCHAT provides immediate and flexible mental health services to underserved children who may not have access without the program. And since the visits are virtual and conducted while children are in school, it also removes the barrier of transportation for parents and minimizes time spent away from the classroom. So those were all really good things that the survey respondents noted. They also noted that TCHAT provides a level of mental health care that cannot be provided by school counselors alone. Respondents discussed how school counselors may not have the level of expertise that some students require, and that there are confidentiality concerns. They also noted that TCHAT provides school counselors with additional support to serve their students' mental health needs more effectively, and provides students and families with a trusted outside provider. So one counselor noted, our kiddos are being seen right away. This is so helpful for our families, and so many of them are grateful for the free services they would not have received otherwise. Also noted some key barriers and recommendations, one of which was complex paperwork and scheduling processes. They noted complicated forms, difficult scheduling system, and parent attendance requirements have all been very challenging for families. Recommendation here is to streamline referral, enrollment, and scheduling processes through simplified forms. Respondents also noted poor visibility into student progress limits program effectiveness, so they would really like to see updates on case status, treatment outcomes, and connections to treatment community resources. And so the recommendation here would be to improve communication while students are enrolled in TCHAT, and to include regular updates on student progress and follow-up care. And finally, respondents noted limited treatment duration and availability as key concerns. They noted that wait times have increased as demand grows, and that this particularly affects rural districts. And so here the recommendation was to increase the number of providers and available sessions, with particular attention to underserved areas. So one school administrator noted it would be nice to get updates on students to ensure that the parent connects with a local provider to continue receiving support. So really trying to find out, what has happened with the student, and how are they doing, and are they getting the referrals that are needed. I will also note that our current surveys are focusing on non-users. So we're focusing on those who are maybe not using the program and services as much. And so we are currently collecting that data, and we'll have that available for you in the next coming months. So I think that's the end of the presentation. Any questions?
Very good. Any questions? Dr. Amador?
One question I had is, do we know the schools noting the improvement was it more so in kind of our more traditional ISDs versus charter schools? I don't know if the data's been broken down more into that.
I'd have to go back and double check on that data, but I can definitely look. My recollection was that there were not any real differences across the districts, but I can definitely double check that just to make sure.
Thank you.
Any other questions? All right, seeing none, Melissa, again, thank you for the work that you're doing and the ongoing evaluation. I think is really helpful as we try to improve the quality of the services we're provided. Quick little before we jump into the next presentation, anybody that has joined us since we did the initial roll call, just so we can make sure that we, from the executive committee, just so I make sure that we have you listed as attending today.
I joined David. This is Jeff Newport.
Okay. Welcome, Jeff. Anybody else? All right. Hearing none. Rachel, let's go to you.
Okay, so I'm going to share our latest data on school enrollment for TCHAD. This is data as of September 30th. So you'll see here that the program is now active in 73% of Texas campuses. That represents 77% of the student population. We saw increases in active campuses in 9 of 12 HRIs this month.
So 4.2 million kids across the state right now. 77% of the student population is now has TCHAT available to them. Right. Very good.
There's just a proportionate view. We have a number of campuses over 300 with implementation dates planned. You'll see here that those dates vary, and we have a number of HRIs working with those campuses to get them onboarded. We also saw increases across a number of education service centers this month. I believe there were also 9 ESC regions that saw increases in active campuses. We continue to see an upward trajectory in our growth. Reasons for decline, the highest continues to be that the campus has existing mental health resources. Any questions?
I did see Marshall was listed twice on that slide. Was there a reason why for Marshall ISD?
Yep, sometimes the district is listed more than once, Dr. Bobato, because there are specific campuses within that district that have different reasons. Okay. I'll move on. Just wanted to give you all a quick update on our TCHAT LMHA pilot. The pilot work group held its first meeting at the beginning of this month. There was a lot of really good discussion and enthusiasm for the work. We reviewed some available data from TRAIT related to referrals to LMHAs. There are some limitations with the data, but it does look like the vast majority of referrals to LMHAs were coming from UT Health Houston to the Harris Center. So we are focusing on the process, the referral process between that HRI and LMHA to identify some best practices and document that process.
So Rachel, it might be helpful because some individuals may not be familiar with what this pilot is doing. Can you give a little bit of background related to the pilot and the goals of the pilot?
Yeah. Apologies for not doing that first. So the pilot was approved by the executive committee the last time we met. Really aims to ensure that our students who need longer term care can be connected to an LMHA. Really want to strengthen the partnerships that we have statewide between HRIs and the LMHAs in the regional areas.
So enhance that coordination between TCHAT and local mental health authorities and handing off care. Very good.
So our next meeting is scheduled for next week. We have invited the Harris Center to attend and share more about the process. We've been preparing a process map to help guide our conversation. UT Health Houston will also be sharing some data that they collect separately about the process and success that we're seeing in referring those students and potential barriers that we may need to address. After that, we'll be able to define some criteria for selecting HRIs and LMHAs to participate in the pilot. I know that there are some of you who have already expressed interest in participating. Don't worry, you're still on the list, and we'll be reaching out soon.
Very good. Any questions, Dr. Amador?
The Harris Health and Harris Center, are they connected in any ways? Because I've heard a few names out there in Houston about community kind of health and resources.
I don't know if the Harris Health versus Harris Center, is somebody in the Houston area have?
The Harris Center is different than the Harris Health. Harris Center for IDD is different.
Harris Center is the LMHA, and Harris Health is the, I guess, the entire county funded healthcare system.
Correct. Yeah, Dr. Amador, they do a lot of work together, but they are two separate entities. And Rachel, I would just say thank you very much for that update. You know, from the LMHA perspective, our folks look forward to being involved in the pilot discussions, and you know, it's really interesting to see the data and the feedback in that Teach-Out survey about a need for, you know, more connections to community providers and you know, a need for some developing of, you know, better connections there. And so, you know, it makes me feel like when I see data like this, that we're headed in the right direction in terms of these discussions. And I know we've got a lot to learn and more work ahead of us, but, you know, I think there's a need there. And just from our perspective, we're grateful for the folks that have been involved in that conversation, Dr. Plitzka and others, and look forward to the work ahead.
Right. And thank you all, all the work group members, for your continued support and the time and effort that you put in already to make this happen.
Very good.
Next, I'm going to be presenting on behalf of Sarah, our ARPA project manager, who's unable to be here today. Sarah has prepared a brief that you all should have received earlier this week that provides some more details about our ARPA integration plans. So today, we're going to be requesting your approval to implement the plans to really begin embedding these ARPA projects into our core programming. We've already done this for T-Chat, and now want to make sure that that we focus on some of our other ARPA funded initiatives. We do plan to implement one plan per initiative, knowing that we have some special considerations for each ARPA initiative that need to be made. So if you all approve the plan today, we'll be moving forward with forming some project-specific work groups. Just a few notes before I get into the timeline. We do know that full integration is dependent on securing, additional funding and authority to continue these initiatives after our ARPA funding ends. We also know we got some recent news that the ARPA funding authorization has been extended through the end of calendar year 2026. So that gives us more time to plan.
It will be extended, right? So the Senate Finance is planning to put, and the House Appropriations Committee to put that authority in language during this session that will allow us to continue the funding. So we'll need to continue to watch that legislation.
We will, regardless of that decision, we will, if you all approve today, we'll be implementing beginning immediately. Dr. Newport, I see you have your hand raised.
Yeah, I do. And I don't understand the full distinction between ARPA and ARPA-H, other than the latter has a hyphen and an H at the end of the name. But we received through TCMHCC ARPA-H funding to support a perinatal clinic in a community health center, akin to, basically it parallels how CPW functions. And I wanted to ask if that will be included and extended into the new biennium as well.
Alex, you want to?
ARPA-H is not TCMHCC funding.
Let us talk to you, because the only dollars we have with $113 million administered through the special session that gave us ARPA dollars. Those are the ones that we have oversight of and are part of. The ARPA-H would be something outside of what the UT system and that we have officially been part of. So I think we can talk offline, but what we are aware of and the programs that we are looking into and continuing are the ARPA funds that were approved with the from the dollars the legislature made available to us through that $113 million.
Okay, thank you. I will follow up with you offline, David, on that. So thank you.
And then just one more important note, we will be making sure that significant decisions are made collaboratively with HRI staff and the folks who have been leading some of these initiatives, and will be bringing those decisions to you all for your final approval before we implement. So here's our rough timeline. I think, Sarah's been calling it more of an order of operations right now because we don't have specific dates planned, given that we may have some flexibility in our timelines. Again, we'll be beginning immediately though. So Sarah's developed this plan. We would like to see your approval today. Following your approval, then we'll be forming some work groups to develop program standards. That will be discussions about things related to scope, to data evaluation, technology, communications, and any other standards, including clinical standards, that we need to work on together and document in policy. So after those program standards have been defined, then we'll move forward to policy development, also putting together any procedures that are necessary. Before any of that is implemented, we will bring those policies to you. Again, just like TCHAT 2.0, we'll be working with HRI staff, with Kosh, with our program leads, to make sure that those policies are, that we can reach some consensus about the guidelines in those policies. And we'll be bringing those to you for your approval after that. Then we will also be developing and delivering training, implementing any technological infrastructure that we need to before we go live and begin integrating. Following integration, we'll undergo a monitoring period before we can then just more regular evaluation and quality. Any questions about our ARPA integration plans?
The next to the performance management plan.
Dr. Wakefield.
Yeah, I didn't have a question. I just wanted to reiterate what a privilege it is to have been able to try to some of these new programs and to do this in the state of Texas. And then thank you for the work that you guys are doing to help us continue to help kids and families in as many ways as we can. And that is appropriate for us to do.
Thank you, Sarah. I think, again, I would thank the legislature for allowing us, we came to them with a variety of proposals that we put together pretty quickly that we would allow us to expand and enhance TCHAT and CPAN and do workforce initiatives, and the legislature funded those. And with anything, some of them are new ideas, and some of them worked perfectly. Some of them had some challenges, but that was an appropriate use of those dollars to figure out how we could be innovative to improve mental health services for kids. And now we're in that phase of taking those lessons learned and the ones that were shown to be successful to take them to scale. And PeriPan is an example of that, that we wouldn't have been able to start PeriPan without those ARPA funds and a variety of other workforce initiatives across the state. And so, again, I think the gratitude goes to the Texas legislature for allowing us that opportunity to be innovative and try some things, and now supporting us as we are baking those into the budget into this next session, so that we can continue those and move them forward. Thanks. So Rachel, you want to go to the performance management plan? And actually, while we're doing that real quick, is there anyone that has joined us since we did the last official roll call? Just want to make sure that we document that you're here.
Hi, guys. This is Luann
Okay.
Southern. I'm here.
Very good. Welcome, Luann. Melissa?
Hi. Yes, Missy DeFilippis from UTMB.
Very good. And Trina Ida, did you join us? Thought you had joined us. But okay, why don't we go ahead and move forward with the next presentation?
Okay. We would also like your approval today to implement a performance management plan that will be consortium-wide for all of our programs. So this will really help ensure that we have some goal-focused administration of our programs, and also ensure that we are doing an objective review of program operations. So that can help drive quality improvements and identify best practices. So just some background for those of us who have not been with the consortium since the beginning. An implementation plan was developed in November of 2019 for our core programs. Since then, we know a lot has changed. Our programs have grown and expanded, and we just mentioned our ARPA funded initiatives, which we hope to sustain. So we have some additional considerations to make since that implementation plan was developed. The implementation plan did include some initial goals and performance metrics. I think now we have an opportunity to build on that, now that we have a number of years of data that's been gathered and analyzed and shared. And we can really take that data and turn it into something actionable. So we'd like to build some baselines and targets and identify best practices. We also know, since implementation, we've developed some program policies, and as part of our ARPA integration plans, we'd like to make sure that we have policies across all of our programs. So being able to track the implementation of those policies will also be important for us to track. So here is our proposed timeline, just to give you an idea of what to expect in terms of scope and deliverables for this project. It is a very long-term, multi-year project. So we've started with the development of this plan. Again, you all should have received a copy of that earlier this week. Doctors Wakefield and Williams really helped us with initial and gathering the initial requirements for this plan, and thank you to them and to Dr. Pliska for your input on that plan. We would like to get your approval today to implement. Following implementation, we'll develop a performance management policy. Again, that'll be consortium wide, just to give an idea of the guidelines and expectations for performance management across all of our programs. Before we implement the policy, we will of course be getting your approval, and we'll follow the same approval process as we have with our other policies. Then we'd like to phase in each of our programs. So this fiscal year, we'd like to focus on PeriPan, CPAN, Safety A, and TCHAT. And we do anticipate that will take us a full fiscal year. We have already begun doing some work at the start of this fiscal year with identifying some potential performance measures and taking a look at existing performance. So this is the general process that we expect all of our phases to follow. The dates are specific to that phase one, PeriPan, CPAN, Safety and TCHAT. So I mentioned we've already begun revising and developing performance measures. We're also going to be developing targets for up to 5 of those measures. We may be identifying additional performance measures that we won't be monitoring, but that we feel is important to provide some transparency to you all, and to just ensure that we have a continued focus on the comprehensive work that we're doing. Once the targets have been developed, we'll be coming back to you all to seek your approval on those measures and targets. And then our internal evaluation team will begin developing and then share performance dashboards that include those measures. And those dashboards will be shared with HRIs and of course with you all. After that, we'll at the same time we'll be identifying and sharing best practices that we've seen just over the last few years, have worked for some teams that have helped them meet targets, and then we'll go through a period of about 6 months where we're sharing and discussing those performance measures and how well each HRI is performing. And then at the start of next fiscal year, we would like to really begin that monitoring and implementation of quality improvements. So I mentioned each of our phases will follow that same general timeline. After phase 1, we'd like phase 2 to focus on our workforce initiatives, our CAP fellowships, CPW, and other workforce initiatives that are currently ARPA funded. Phase 3 will begin the next fiscal year. And we'd like to focus on YAM and collaborative care. And then finally, our last phase will be focused on our research initiatives. Any questions?
Any questions for anybody? Yes.
Just to comment, it's an amazing work. Like, this is really terrific that you're starting that evaluation program. I'm assuming it will be iterative, so after getting the results will be ongoing phases.
Yeah.
Thank you.
I think since we're now 5 years in, the first year or so was just figuring out what this was and trying to quickly get dollars out and move. A lot of variability, which was good across our HRIs. We've grown a lot since then, and we've learned a lot since then. And now it's kind of an opportunity to make sure that where it makes sense, to bring us together in a similar approach to a variety of things. Where there's reasons for there being variance, understand that, because you know, Texas Tech will be very different in Lubbock than in Dallas, and we have to understand those variances. But we can also learn from each other. And I think where this can be very helpful is that as we looked at the next budget cycle, as we're trying to figure out how do we grow and justify growth, et cetera, to have come to a consensus across our HRIs of kind of this is what it takes to deliver this program and kind of those metrics of justification of additional growth. Any questions from anybody? And again, this is an iterative process. Everyone's involved. Again, this is not in any way, you know, to be done without everyone being part of this to make sure we are in agreement of kind of what we do to measure ourselves, and so that we can tell the legislature and others that we are continuing to try to be the best stewards possible with the resources that they have generously provided to us to provide these programs. Okay. All right. With that, Dr. Wakefield, I think we're going to go to you for an update on the Prairie Pan implementation.
Sounds good. I think we'll pull up the slides and I'll wait just a second. Excited to tell you guys what we do.
Sarah, I have been, I just been corrected. I think I need to have a formal vote on the on the performance management plan, right?
And the ARPA integration.
And the ARPA integration timeline. So I'm
Dr.
going to hold off, Sarah. Yes.
Dr. Lakey, I'd like to move that we approve the ARPA integration timeline and the performance management plan.
I have a motion and a second by who seconded that?
Sarah.
Sarah, I have a motion and a second. Any further discussion? Hearing none, all in favor signify by saying aye.
Aye.
Aye. Opposed, nay? Did anybody abstain? So let the record show that there's unanimous approval for both of those plans. Now, Dr. Wakefield, we can go to you. Thank you.
Great. Well, very exciting. So I saw it and then it went away. Can everybody else see it? You can see it? I can't see it. Oh, you can't see it.
No, it's something funny right now on the screen.
You went away.
I could talk through it too. I have them up on my side if we have a technical problem.
There it is. And then we went to full screen and it, yeah,
it doesn't want to go to slideshow. Okay,
all right,
yes.
we're going to just yeah.
Perfect. Great. So Perry Pan enrollment, wanted to say we continue to make progress here. There are 987 obstetricians over the state, in the state of Texas, who are enrolled in Perry Pan. And of course, our family medicine docs and our pediatricians who originally enrolled in CPAN are also enrolled in Perry Pan, but that's not a metric that we're tracking anew with the Perry Pan rollout. And this covers not only obstetrician clinics, but women's and maternal health clinics and midwifery practices as well. Next slide. So just to show you guys that our, the goals, we want to continue to see increased call volume. And we did have kind of our biggest jump that we've had from September to October. So we're really excited to see that. We've continued some aggressive outreach efforts as was kind of outlined in one of the recommendations from the external evaluation team for the CPAN program. We expect that it is the same for Perry Pan. I think Dr. Williams and I can both say that we feel like we talk about these programs all the time, as many opportunities as we can get, and it continues to be surprising when people say they've never heard of the program again. So we are working closely with our Center for Healthcare Communications team on what are strategies, what are effective strategies, and with our access centers and health-related institutions around the state to try to do that additional outreach and effective outreach. And we are seeing some reflection of progress related to that. So we're really excited. We have increased first-time callers, increased repeat callers, and we're seeing that call volume go up over time. Next slide.
That's pretty impressive. So that's a 20% month-over-month growth. So that's good. Thanks.
Yes, it's, you know, that I would like to see it higher. We're going to continue to work to get the word out and to be as accessible of a resource as we can to our very busy obstetrician clinicians. But we are excited to see that growth happening. We continue to have obstetricians be the primary caller when we're looking at the breakdown of physicians who are calling, or the frontline clinicians who are calling, working on splitting out that resident number so that we can put those in the categories of what clinical training program, in which clinical training program they're participating. And then our next most frequent caller are pediatricians. And so this data has stayed pretty consistent over time. Next slide. And what's also been consistent across both of our programs, CPAN and PeriPAN, is we've seen 60, about 2/3 of our calls being not going, the psychiatrist is not involved in that call. That call is really for getting the clinician as many resources or education as soon as possible, handouts for that patient. And then about 1/3 of our calls are being answered by the psychiatrist to give more clear direction on diagnosis and medical intervention. Next slide. This is a slide that we'll continue to work on. This is our direct patient consult slide. We expect that this would follow the same as the call volume slide, that it would increase over time with that call volume. We changed this month in October to having a new flow for direct patient consults, where those are put into the trait system, and that's where this data came from. So we're reaching out to all of the different HRIs to make sure that we're reflecting all of the direct consults that occurred, because we'd also expect this to increase over time. To remind everybody that when we're on the phone with a clinician and a psychiatrist a reproductive psychiatrist is visiting with that clinician, there may be times that we are not understanding the diagnosis. We're not clear on what those presenting symptoms are. And so we're not clear on what to do about it. And in that case, we can do a one-time direct telehealth assessment for diagnostic clarity and to help guide those next steps in care. So we would expect to see, as call volume increases, that the need for direct patient consults would increase as well. So we'll do some further investigation and support for this, because the data from other states shows that the direct patient consult is really what drives the future utilization, that this is the service. This is the primary service, not the highest utilized service of the Access Project, but this is the service that drives future physician engagement or repeat engagement. So we want to make sure we see these go up over time. Next slide. All right, so to talk to you guys about a little bit of a few of the collaborations that we are involved in across the state of Texas and beyond. So the first that we'll talk about is the Pathways program. This was approved by the executive committee a few meetings ago. And this is the ability of teaching the Access program how to provide technical assistance in screening and referral and utilization of the Access project. When this work was done, the pre-work to this PCORI grant showed that if we were able to help a clinic in their patient workflow, when they were screening, what to do with that screen, what to do in the referral, and when to call the Access Project, that the Access Project utilization went up and the outcomes for patients improved. So we joined that project, the PCORI project, with Lifeline for Moms, and have identified are in the process of identifying clinics in multiple regions of the state that have been looked at for the maternal health index, access to care, rural nature of them, and various other factors that we looked at for the qualifications for the study. And so wanted to talk to you that we're really looking at, we've gotten clinics in the Houston area, in the Permian Basin, in the Amarillo area. We have probable yeses from some clinics in the Tyler area. We're continuing to work in the A&M area as well. And so and UTRGV. So we've had outreach in those areas, but have not been able to get so far clinics to agree or really respond. So we'll be reaching out to those health related institution peri-pan teams to help us make sure that we're not passing on an opportunity for these clinics. And just a reminder that everything that we're learning, we're building this in a way that the entirety of peri-pan, all of the health related institutions will learn the skills and techniques to assist with technical assistance. But we needed to identify at least 8 practices as a part of this actual study. I'll pause to see if there are any questions about Lifeline for Moms or the PCORI grant here. No. Okay. So I had the honor of participating and presenting at the Texas, as you may know, is big enough to have its own district under the American College of Obstetricians and Gynecologists. And so I had the privilege of presenting at their annual meeting, and it was really exciting to I presented to their junior fellow council. And so a lot of these, some of these are newly graduated obstetricians and gynecologists. Some of them are in fellowship, some of them are chief residents. But this was a really energized group of individuals, and was really exciting to present to them. So we are, I was able to talk to them about our toolkit and other resources. That was another group that wasn't totally familiar with peri-pan and the services that exist under peri-pan, but were really excited. And so just an encouragement to all of the peri-pan teams to maybe focus on, at least have an outreach to the residency programs at your sites, the obstetrician residency programs, because it's a really energized group of clinicians, developing clinicians who were really excited about this, and will be going out, and able to practice in Texas, and they're able to utilize it as residents as well. I was able to meet Dr. Stella Dantas there, who is the president of ACOG, of the overall national ACOG, and work with Gail Olson, who is the District 11 president here in Texas. She's down at UTMB, and she's been working with us on how to improve outreach around peri-pan. And so thinking through some ways that ACOG can support and help us get that message out. We're working also for a pocket card to condense down our toolkit into a pocket card guide, so that that will be, every time they look at that pocket card to help them with screening and guidance, it will also say peri-pan on there and remind them to call and utilize the service. So the ACOG would help us distribute that. So working on lots of ways that we can provide outreach and reminders that this program exists and wants to help support the mental health and well-being of moms, pregnant postpartum moms in Texas, so that we can do some great prevention work for the mental health of children. All right, and the last one up here is our Be Well Texas. We are working through, we were part of a HRSA grant application, and we are working with HHSC and UT Systems. We've to be able to collaborate with Be Well Texas, we're really focused on substance use screening and treatment. As you probably all know, one of the leading causes of death in the first year postpartum for moms in Texas and nationally is overdose. So we want to make sure that peri-pan is well informed and has well-established relationships to provide appropriate referrals for treatment, and and education for our clinicians. So Be Well and peri-pan will be partnering together to work on both educational initiatives and referral treatment patterns, and education to our peri-pan reproductive psychiatry clinicians to increase capacity of this across the state. And so we have our MOU complete, which took a long time, as you may know, getting lots of systems to work together on, and we are moving forward with that. So very exciting. I'll pause for a second to see if there are any questions, and then we can go to the final slide. All right. So the other thing that has been really important to me as we develop this education is looking at or is developing PeriPan is looking at our educational initiatives and making sure we are not being, we're providing as robust an educational curriculum as possible. So over the pilot year, we provided an educational curriculum every month, both webinars and then echo series throughout the year. We decided to repeat that curriculum the second year when we went live across the entire state because more clinicians had access to that and we didn't want to move on. But we have now created a 2-year rotating curriculum that we think really has fantastic condensed down objectives for what are the highest yield kinds of things for our obstetric and pediatric and family medicine and frontline clinicians who are taking care of pregnant and postpartum women. So we're excited about that. We're also working on condensing down those webinars into pearls and case discussions so that those can be accessed on the website to facilitate resident education at your sites as well. So we want to encourage all residents, psychiatry, obstetric, pediatric, family medicine, to attend these webinars and then also to access case-based discussions and the pearls to help them kind of internalize this information going forward and really rise all boats so that we can take better care of moms in the future. And that's all I got.
All right, very good. Any questions for Dr. Wakefield? Well, obviously, you guys have been very busy. And again, thank you, Sarah, for the great work in expanding that statewide and letting people know that it's here. So let's go now to Dr. Williams. And Dr. Williams, can you give us the COSH update?
Yes, I can. Here's the slides. Wander back. Yay, there they are. Happy November, everybody. I hope your November is going okay. Next slide. I'm going to start obviously first with CPAN and the next slide for CPAN. We continue to see overall our call volume is increasing. We did have a dip in October, which is a little weird, but overall the call volume has been doing a steady rise. I do think that this is in part related to the outreach efforts. So referencing back the external evaluations teams sort of comments about like not enough people know about the service. I 100% guarantee everybody in the executive committee that every single one of our CPAN, PeriPan teams, because they're combined, go out every week in a variety of ways to provide information about the program. We go to almost all the all the state meetings related to OB-GYN, family medicine, pediatrics, psychiatry. So we are definitely having a lot of collaboration around that. And I do think that is part of the reason for why we're seeing our volume continue to rise. Next slide. So this is just, again, looking at that rise, Dr. Lakey, from year to year. And so you do the math on the fly better than I do, but just sort of overall global look, you could see that our call volumes are continuing to rise from year to year in our program. So we're very glad to see that. Next slide. This is similar again to the slide that Dr. Wakefield shared related to which members of our team are involved in helping a primary care clinician. As you can see, the vast majority of our calls do center on providing resources and materials, helping find a referral for the patient. We do want to, disclosure, as again, speaking to the external evaluation team, if there's not a resource to be found, we agree it's very frustrating when we ourselves cannot locate a resource. We definitely do recommend telehealth resources when indicated, if the family would be okay with a telehealth resource. But sometimes there really is just a difficulty in finding an adequate resource, depending on the needs of the person as well as their insurance status and all that. So we continue to work very hard to keep ourselves as up to date as possible when it comes to those resources. But again, the 2/3 of our calls do involve our team members doing that sort of vetting. We don't just give them a list that hasn't been vetted. We do call and confirm that these resources are still available, what their estimated wait time is. Yes, they take those insurances or not, all those good things. And then about 1/3 of our calls, 35% or so, are going to our child psychiatrist. So When we look at national data related to access programs, this is on point with sort of the ratio of what access programs do with their programs. Next slide. And so this is our direct consultations by month since, as you can see, January of 2024. We have overall seen sort of a steady rise, generally speaking. Actually, these are the actual consultations that were done. For example, I'll give you the October data. We actually had 167 recommended in the month of October for a direct consultation, but 54 were completed. Again, a direct consultation obviously requires a lot more coordination because we have to discuss that with the primary care clinician, they agree or not. Then we reach out to the parent or legal guardian or the woman, get their consent to do the care and then do the appointment. So as you can see, there's lots of reasons why we're not always going to get them done exactly on the same month where they've been recommended. But these are the actual ones that were completed as of each month. We did go live with the direct patient consultation process that Dr. Wakefield was discussing in TRAIT in October. That's the second week of October. So moving forward, the teams will have a dreaded spreadsheet they won't have to fill out anymore because the data will be available to us in TRAIT with a lot more specificity, which we'll be happy to share with you in coming months. Next slide. So again, as I just sort of preface, we did do a direct consult release process. So starting in October, the process for collecting the information that we need to kind of look for program effectiveness, look for ways for quality improvement started. It also has an automated way for us to send out the standardized letter once our team member has seen the patient, done an evaluation, creates a letter that goes to the primary care clinician. And then also one of the biggest teaching and important points of a direct consultation is that after that patient is seen in an appointment, the best sort of part about CPAN direct consultations, to Dr. Wakefield's point earlier, is that we will have a follow-up consultation call with that primary care clinician to walk them through the recommendations, help them really with any additional questions they have, because the goal of this is to not have the patient just be seen in a specialty care service. The goal of this is to help primary care, when possible, provide the care in their own office and not have them be transferred to a specialty care when they could be safely managed in primary care. So we're glad for that release to have happened. In November, we also did have an additional tool that was added around that issue of engagement. Again, we have now automated the process for primary care to let them know when they've been newly enrolled. They'll get an automated message that the CHC team helped us craft for when they newly enroll into CPAN PeriPan. They also now have automated messages for when they start a consultation. And because we can have up to 2 working days to complete a consultation, because sometimes we need to go dig with those resources, we have another time where we'll have a touch point with them, emailing them when that consult has been archived and we have completed the service for them. So we're excited for that. Next slide. Speaking again to Dr. Wakefield's point for education, we certainly are working hard to make sure that the education that we provide people is evidence-based and up-to-date and informed. So we have been creating, we have work groups that we've been working on specifically the resources that we provide. We have now, I think we're on topic number 4 with depression. This is a pretty labor-intensive process, but the end goal is to really make sure we have the best, well-vetted resources, materials available, broken down by age and population of resource, so that whether a PCP calls us about depression, wants to know what they might give a teenager about depression, we would be able to have ready at the hand. All of our team members would be able to share the same information to that primary care doctor. So those work groups have been going on now for about a year, and they take about 2 to 4 months to kind of complete their work, because it's very, like I said, labor intensive to make sure that we're not missing any resources, but also that we potentially retire resources that are no longer evidence-based or not as up-to-date as they need to be. The other thing that we've been doing is working to standardize our CME activities. And so we've started with a work group with our with our clinicians in psychiatry, developing slide decks that would be used across the state for ADHD. They're kind of in the final stages of doing those slide decks. After those slide decks are reviewed by them, we'll show them to all the psychiatrists in CPAN. We also get primary care clinicians who work with us to review the slide decks to make sure they really stay on point to high yield information that's needed for primary care related to each of the topics. The goal is to have over time a cache of already created content that we can have people on the fly do a presentation, as well as just statewide. We're all providing the same type of information when it comes to these core topics in mental health. So that CME standardization work group is, I'm hoping they'll have that finalized and with feedback about how to do that work, so we can have several groups working simultaneously at the same, well, that's a work simultaneous means at the same time. So we'll have a couple of work groups working on different topics at the same time to kind of speed the process up. Next slide. So one of the things that we are wanting to be excited about is that because the teams have gotten busier, there's more work, there's outreach that some of our team members are doing, there's direct consults that some of our team members are doing on any given day. We really need to make sure that we are really one team working all together every day across the state to really make sure we're maximizing the resources that we have and that we're all working together. So several months ago, we instituted a daily huddle so that the leads of each CPAN Peri-TAM team meet briefly in the morning with Edith and Jen to just make sure there's any operational concerns that people may have. We've also created a coverage calendar so that if Dr. Wakefield is out and she's not going to be on a Friday, then the team knows that she's not available and who another across the state could maybe take calls while she's not available. So having an up-to-date calendar, and also just making sure that we have anything that's sort of unusual or different about today that a team is having. Oh, somebody's car broke down. Did somebody cover for them? We can make sure that goes and happens very seamlessly. So we're very excited to see that improve the communication across our teams with this daily huddle. We also have an SOS chat. So even in the middle of the day after huddle, if something comes up and you need something quickly, so Dr. Williams had to step away unexpectedly and now she's not available. And so there's a call coming in that a pediatrician needs a callback right in the next 30 minutes. One of the team members can hop on and say, yep, my doctor's available, and make sure that that call gets taken care of in that moment as needed. So we're glad to have these sort of additional ways that we communicate with each other. We do find that there's challenges still that we're trying to work on. And so we just want to be aware that one of the things we really are trying to standardize is that idea of like what to do if there's an SOS to make sure that everybody responds quickly in a standardized way, so we can really make sure that we don't miss any calls, miss any deadlines with our 30-minute callback metric in particular. We're also finding sometimes that potentially psychiatrists who look available on paper are maybe not available when we contact. So we really want to ensure that all the executive committee members are aware that if you have psychiatrists that are on any given day saying that they're doing CPAN, Peri-TAM, we're okay if they're like, they're working on a paper or they're doing some kind of work, but they need to be able to immediately step away and take a call. And so we actually don't want to have a process where the psychiatrist says yes or no. We just want to be able to say yes. If Dr. Wakefield is on the list that she's available, then she can take a call. We don't have to do a back and forth. We can just transfer that call seamlessly to her and get that call done. So that's a piece that we're still kind of struggling with, and we may need to kind of provide some additional guidance to every team to make sure that if your name's on the list, you're available to take calls. And so that's something that we're just going to continue to work on.
Thanks, Dr. Williams, for bringing that up. And again, thanks for the work for doing this. I think that's the value of this consortium, of us working together, because there are times when different people have to be away. There may be maternity leave, there may be a variety of things that are occurring, and we need to be able to work together across the consortium. And so that calendar of when people are listed to be available, we really don't want to have somebody listed there and then not being available and then have to scramble around. And so would ask the chairs of psychiatry just to reaffirm that with your team, that this is important in order for us to keep that efficiency of the consortium to where we want it to be. And that they're funded with these funds and are available, that we really need them to make this a priority. So thanks.
Thank you. And even though the next slide is teach, I must say one more CPAN thing. Just again, Dr. Peskin from the external evaluation team, we are aware that providers would like to potentially have additional ways that they could, send in a consult because of their time constraints in busy clinics. So Part of the ARPA funding was to create a PCP portal, and we are working on some of the first phases for that portal development to make sure that we have a secure platform that people could send in their consultation request, you know, after hours at times that are more convenient to them, potentially get that information back in that sort of a format. So we will be sharing more about that in the spring as we get closer to the implementation. But we've heard it from the primary care team world, and we are working to address that issue. And so I just wanted to say that. So next slide, TChat. Next slide. So again, we're very honored and pleased to sort of see that we are continuing to see a rise, just like with CPAN, with TChat, year on year with the number of referrals that we're having come into us across the state for our TChat team. Next slide.
Laurel, sorry to interrupt you, but again, I'm just kind of looking at some folks in this room, kind of 5,000 referrals over the last year. So that's going to be, and I'm going to do a quick math here, but 28% year over year increase in the number of referrals this year. And yeah, so congratulations to all the people that are working in the TChat programs, because that's a lot of work. And so thank you for doing that.
Next one. Yeah, so this is, so referral is of course when the school sends us the referral, after they've asked the parent, would you like a referral? This is actually when our team has made that first contact with the parent and legal guardian, and the parent and legal guardian has said, yes, I would like the service. So again, once we do want to have that clear distinction, I know that the external evaluation team did talk about how schools would like to have more information. We just want to really kind of keep highlighting and reminding people this is healthcare, and the family gets to decide what the school knows or doesn't know about healthcare. So even though schools sometimes want to know information, we have to keep reminding them that sometimes it may not be information that the family would like to share with the school. And so we need to, of course, honor first what parent and legal guardians want to share and don't want to share. So this is that sort of point that there's a difference between the referral number and enrollment. And we have more specificity in data that we're continuing to look at about those differences. But we still had an extremely large amount of enrollments in that month of October, which is always a peak for us. Next slide. And this is, again, just looking at the number of treatment sessions that you see also versus the students. And once again, this is year over year growth because you're looking at a couple of years across that access line. But basically, you can see those summer months when we have less referrals. We continue to get referrals during the summer, and we continue to treat young people during the summer. But of course, it is generally speaking, a lower time for our TChat team. Next slide. And this again is just showing once again that the vast majority of the care that young people are getting in our TChat services, which makes a bunch of sense because most evidence-based treatments for most common mental health disorders in youth is a psychotherapy or psychosocial intervention. So the vast majority of our young people are getting help with our psychologists, our social workers, our LPCs, and additionally, as we need to potentially hand off a care or have additional things that a person might need, that case manager has been very helpful for those families for that transition out of TChat. And again, that pilot to sort of help us connect the dots even closer with the LMHAs is very welcome and needed, and we're excited for that. Next slide. So as you had approved us to go ahead and have some additional assessments crafted and created that will be standardized and will be sent out. This is just sort of reminding you that work is done. We have the CIS both start and every fourth session, or well, actually it's every third but fourth session done. That has now been standardized. Now we are working to standardize when these additional assessment measures will go out. Once again, trying to help that efficiency, help team members, you know, get those things done, and collaborating with the families and children based on the child's age. They will have different measures that are considered evidence-based for that age group. Next slide. So we are continuing that work in that measurement-based care support. We're working to incorporate those assessments. We will be operationally sharing with teams their sort of completion rates for those, so that if we can identify early if people are struggling with with that, we are continuing to do sort of on-site operations support with select HRIs that are needing just a little bit additional help to keep their programs running smoothly. We are working to collaborate with that CPAN WellNeti so that we have one large database that again stays up to date, because what is expected in WellNeti is if I, Dr. Williams, get a resource in WellNeti, I have to verify that, yes, I called, I checked, this is still an accurate representation of what this particular service does. Or if there's something needed to change about it, I edit it in the moment. So the next person that pulls that research up, even the next day, would have the most up-to-date information. So the goal of WellNeti is this sort of constant improvement and making sure that it's the most up-to-date. We are continuing to work with the UT system and the CHC to develop additional resources and materials for general use for outreach efforts, as well as just communicating with schools, with families and with youth. And we are continuing to work on providing support to how to sort of present ourselves when we go to externally facing conferences. And so the CHC and UT system has been very helpful in helping our T-Chat teams with that. Next slide, and it is the last slide. So the school dashboard, so there is information we can provide schools, namely how many referrals you've sent, which numbers of referrals have landed with an enrollment. We don't do it by student because, again, it's about student privacy, but they can have high-level data around their referrals and sort of where the referrals have gone and what process, what step they're in. We are working on the end of care survey being finalized. That is now actually happening in November. Sorry, I take that back. And so now we have an ability to, once the service has been archived in TRAIT, automatically send to the parent the survey about the services. And we've actually been getting a lot of immediately positive, much more increases in families responding to the survey. So we're excited for that. We are working on that automation, as I said. Single sign-on is in process for those HRIs that have single sign-on. And then eventually EMR integration with some select data points for teams. So a lot to be done in the future. And thank you. I'm open for questions.
Very good. Any questions from anybody? Yes.
So there's a couple of questions. So first, thank you. This is very helpful actually to see. So with respect to the availability data of providers, like, is it possible to share the data with the chairs just to understand kind of the department by department?
I think so. Yeah, we can work on that. Laura, anything you want to say about that? Yeah, we can share that.
My second question, and maybe I should know the answer to that one, but how, with respect to CPAN and Veripan, how integrated is the referral process into the electronic health records that people are using? Like, or do they, so as a provider, do you have to, are there any prompts, let's say if you're doing assessment, to prompt you to do a referral across the different systems?
For CPAN?
For both CPAN and Veripan.
So when our team gets a call from a primary care clinician who needs resources and referrals, we look for those resources and referrals, and then we send them to that primary care clinician, typically either via email or fax. Actually, in some of our rural counties, they really prefer faxing than an email. So I don't know if that's answering your question, but if we're sending a resource, that's what we do.
I guess my question is more on the person who's doing the referral. Are there ways to prompt them, to trigger them to do a referral? If there is something,
I think, you know, where you could do that within your own system, and looking within your own system and your Epic. A lot of these individuals that are referring are out in private practice and may not be part of our HRIs, and therefore wouldn't have we wouldn't have the ability to, you know, help with those. But we've tried to make it as user friendly as possible. Any other questions? You know, again, Laurel, you know, just again doing quick math here, as you're going through that, it looked like to me like referrals went up about 25%, enrollment went up probably by a third, so probably about 33%, and year over year number of sessions probably went up about the same, probably about 33%. And so business wise for our folks, just again, we know they're busy, but documenting that basically 30%, 33% year over year increase in the number of sessions is pretty, I think, significant and impactful. And that's part of the reason why, as we're looking at this next legislative session, that there are increases in the budget, because we are much larger now in the number of schools that we're serving, number of consults per school, and which results in that 33% year over year growth in the number of sessions.
Thank you.
Any other comments? All right. Thank you again, Dr. Williams. So let's go to Dr. Norcross. He has been working diligently on setting up the triple board program and has other things he'd like to update us on. And it's really appreciate Dr. Norcross, you being here today and sharing your work.
Sure. Thank you very much for the invitation. We're excited about some of the things we're doing at UT Southwestern. Go ahead and go to the next slide, please. So some of you may or may not be that familiar with triple board training programs, but obviously our goal is to train physicians to be great clinicians, leaders, and advocates, which is so often needed for children with co-occurring psychiatric and physical health illnesses. And so a triple board track or program includes 24 months of pediatric training, 18 months of general psychiatry training, and 18 months of child and adolescent psychiatry training. So finish in 5 years, basically. We do these sequentially right now in our triple board program. So the folks we match out of medical school start off with 24 months of pediatrics, then move into general psychiatry, and then child and adolescent psychiatry. Next slide. So there are only 11 triple board training programs nationally. We were actually the 10th program in existence. And now there are 11. It's a small group, but a very energetic group of folks that are really working hard to expand this. We have 4 slots per year in our triple board program. And we learned when we started, we were actually at that time the largest program in the US. We have seen some significant interest, an increase in interest in triple boards, which is really exciting. When people complete the program, they are board eligible in pediatrics, psychiatry, and child psychiatry. And we do have 2 faculty at UT Southwestern that are boarded in all 3 specialties right now, which has been great in launching our triple board program. We have partial funding, both from the Texas Child Mental Health Care Consortium and also from the Texas Higher Education Coordinating Board. When we started, we asked for funding from both organizations, and they were both kind enough to provide that, which is one of the reasons that we were able to start with 4 slots per year. We kicked off the program in July of 23, and in our first class, able to fill all 4 slots. For July of 24, that we were also able to fill all slots. And as of right now, we're in our recruiting time and getting ready to start interviews for our 2025 slots. And we have 105 applicants for the 4 slots right now. So again, to say the interest has increased, I guess, is somewhat of an understatement. Now,
that's pretty amazing. 105 applicants for 4 slots.
Yes.
Congratulations.
Thank you. And you know, we're obviously going to interview as many of those folks as we can. We do have to arrange interviews with pediatrics, general psychiatry, and child and adolescent psychiatry. So it does take coordination. We will actually have our first graduate, however, in August of 26, as we had a physician from the general pediatrics program apply for and asked to transfer over after her first 2 years of pediatrics. So besides our regular filling, just kind of organically with year 1, we had a year 3 person also start. So she will be finishing the program in August of 26. And, you know, as it being a 5-year program, we'll have, once we fill up, we'll have approximately 20 trainees per year, so, in all the 5 years. Next slide, please. I just want to recognize our leadership and really stress that it does take a village in a lot of ways. We have training directors for psychiatry as well as pediatrics, and our vice chair of education in psychiatry and in pediatrics, all involved, and it takes a lot of coordination. I will give kudos to Dr. Trello Rochelle, our child psychiatry training director and triple board training director, as the lead in this. She's the one that did all the legwork, getting these approved nationally and got us started. So we're very fortunate to have a good team that's very interested and provides great support. Next slide, please. Besides triple board, another expansion through the TCMHCC CAP fellowship is we're creating another child and adolescent psychiatry fellowship position that is specifically for community psychiatry. So in the match, we'll have one community psychiatry position, and our other fellowship positions will be general child and adolescent psychiatry. And we are recruiting for this right now. As you can imagine, we want to further expand the community focus in training. And we have community tracks in our general psychiatry program. So we have a framework for this already. We're going to have one position in the match, hopefully, to start in July of 25. Emphasize community psychiatry, and their second year, which is majority of an ambulatory job, will be with our CPW partners out in the community. Their first year will be a lot of hospital-based work. And then we're excited that in 2026, a good portion of that hospital-based work will be done on our campus at the North Texas Behavioral Health Center, which is the new state hospital project that is well underway construction-wise and actually a little bit ahead of schedule. And we will have 92 child and adolescent beds, including 12 med psych beds for kids, as well as a small PHP for step down to reintegrate kids into the community. And again, you'll see Dr. Trello Rochelle's name there again in the terrific work she does. So we're excited to increase the child kind of community presence that we have, including the state hospital on its way. Next slide, please. We are also gearing up for our Women's Mental Health Fellowship, somewhat of an offshoot and partner of the Perry Pan program. We're hoping our inaugural class we're planning our inaugural class to start in July of 25. It is a 1-year fellowship with 2 positions. We are not officially in the match right now yet with this program, but we do have one slot that we have a trainee for and are working to find a second for somebody that's interested. Their rotations will concentrate not only on perinatal psychiatric disorders, but trauma-related disorders and substance abuse, and time with our eating disorders program, all which obviously can be serious consequences to perinatal and immediate postnatal conditions. They will participate in our Perry Pan program as part of their rotations, and also do community rotations as well as hospital-based rotations, and complete a scholarly project. Mitra Dodi, who is a perinatal psychiatrist that's quite involved in the state of Texas and was one of the architects of our Perry Pan program, is going to be the training director. So we feel like this is going to be in very good hands. Next slide, please. And then our last slide is a little bit about our HRI partnerships with other HRIs. In TChat, we've done some work from February through July of this year, and through Kasha's program of helping HRIs that might need resources be able to access them in other HRIs. We've been able to provide some of the therapy services for TCHAT. And then the local HRI provides the case management and kind of direct boots on the ground connections. And with the San Antonio group, we were able to complete 19 referrals and 88 with UTRGV. So we appreciate the cooperation and collaboration we've been able to have with those other HRIs. And then we are working right now, again, also with UTRGV and Dr. Chapa through CPWE to be able to staff a clinic that's going to be in Laredo, one of their LMHAs, Border Regional Behavioral Health Center. And we will have one of our child psychiatry faculty involved in CPWE do virtual supervision and education with that group. And so, again, excited about being able to collaborate around the state. So I think one of the fun things about TCMHCC that especially is really coming to fruition now is the integration and collaboration around the state and kind of getting to know our partners instead of just staying in our small area. And we feel lucky to have been able to do this. And that's it. Thank you very much.
Thanks, Jim. Yeah, great work on the training programs, but also the support that you're providing and filling in some gaps where needed. You know, the other part of that I know that you guys are working on is that there's some educational needs in general psychiatry, and you guys are trying to help with didactic education for a variety of the members here of the consortium, and even looking at how you can be leveraged to provide some supervision in this more general psychiatry. But that allows some of the smaller programs to flourish. And so, again, appreciate the collegiality and the partnership that our institutions are providing.
Yes, thank you. Yeah, Adam Brenner, our Vice Chair of Education and General Psychiatry Training Director, is leading the charge on the educational collaborations, but our plan is to do it in general psychiatry and also provide it in child and adolescent psychiatry for those that are interested.
I think that's a great story. And again, the more of the stories of how we're working across the institutions to support each other, helping each other out so that we can address the mental health needs for our kids, the workforce, and the training challenges, I think is great. And I think we need to share those stories. Luann?
Hi, Jim. Thank you so much for that presentation. I was thinking your presentation about this supervision across the state made my wheels start turning. And I was in Midland several weeks ago, and there was a big conversation about the dearth of children's mental health providers out there. And I was just thinking how cool it would be to be able to do some virtual supervision of children's mental health professionals in our very rural areas of the state. That would be just so cool to be able to do that. So thank you so much for what y'all are doing. I think it's pretty fantastic, and the opportunities are endless.
Thank you, Luann. Nice to see you. And I have to admit, being a graduate of Texas Tech School of Medicine myself and training in Lubbock and El Paso back before they were separate institutions, I recognize the need in West Texas, and we're certainly happy to partner and continue to try to develop this, in any way we can. So thanks for the shout out.
Very good. Dr. Papachuk, I've seen your hand go up and down and up and down a couple times.
Yes. I'm so sorry, guys. I just have to comment and say this is incredible and impressive work, Dr. Norcross. This is amazing. Incredible. One question I want to ask for the psychiatry and the CAP rotations, are there specific rotations that you prioritize in the 18-month programs for each of them? And are there any specific ACGME requirements for the PD or for the trainees to actually have?
So we do have to meet ACGME requirements, which include the amount of intensive rotations, which, as you know, can be residential, inpatient, or PHP. And we have inpatient and PHP, options here. We don't have an RTC. And the long-term kind of outpatient requirement is actually there too. Now, I'm going to embarrass myself just a little bit and say, as I'm not the training director, I don't remember the exact numbers, but we do follow carefully those numbers. And there is also a pediatric extended kind of long-term clinic, and they will do some pediatric work into their psychiatry years also. We are a partner with Children's Health System of Texas, our pediatric hospital here on campus in Dallas, and there's a campus in Plano, and we are now just in early talks with pediatrics about also developing a triple board program, a clinic where we can have our triple boarders, provide both sets of care. But that's in very early discussions, and we haven't gotten that approved by everybody, but are interested. And since we have some faculty that are boarded in both pediatrics and psychiatry, they also have an interest in doing this. And so, we want to make the experience the best we can. So I appreciate your nice words, and I'll find that information out and send it on to you.
Thank you so much. I'll be looking forward to it.
Any other comments or questions? Just one quick observation, Jim, with 105 applications this year, if other institutions are interested in doing something like that, it looks like there's a lot of people interested. And I'm sure, having worked with the people at UT Southwestern, that they would be more than willing to mentor and educate people about how to do that. And again, if there's ways that we can be supportive in that, would be happy to think through that with our institutions.
Yeah, I am very happy to volunteer Dr. Trello Rochelle's time. She's not on the call. No, I know she would be happy to. She's just done an amazing job, and we're happy to discuss this with anybody else. There aren't very many, as you know, again, we talked about, there aren't very many of these programs, but I have an idea that they're going to start growing rapidly with the interest of people coming out of training, and how it's now very hard to match in general psychiatry coming out of medical school. We've had such an increase. So, this is another interesting way to go.
Yeah, very good. All right, we're at the end of our agenda. I don't think there's anything else that we are supposed to bring up. But again, want to thank you all for the work that you're doing in your institutions, and the way that you're serving the kids and your residents and your trainees. I wish you a happy holiday season, Thanksgiving. For us here, we are working on a variety of things we talked about today, but also getting ready for the legislative session. And again, we'll look forward to continued communications with folks as the session moves forward. And we hopefully will know that, a month or so, kind of where our base budget is. So we've been working with the legislative offices to try to make sure the needs of the consortium are addressed. And again, having 33% increase year over year in volume speaks volumes of why these services are needed, and why the increased resources will be needed to meet that demand. So, appreciate the work from everybody, and we'll see you soon. Thank you.